Functional shoulder. So what we call that as a missing link. So shoulder problems is one of the commonest condition a physical therapist encounter across the world. I mean, it's a very common than actually back pain and neck pain. Um, the reason being, shoulder is one of the common segment get influenced by a lot of other joints and regions around it. So what that means is, so the shoulder joints is one of the commonly get affected. It's usually become a culprit than a victim. So you guys understand the difference between the culprit and the victim, right? So the culprit is the one that's causing the dysfunction and causing the pain. The victim is the one it shows it up. So most of the time, shoulder joint is a victim rather than a culprit. So that means someone somewhere else is the problem that's leading to the shoulder dysfunction. So, first of all, I'd like to thank my mentor, Earl Petman. He's a Canadian physical therapist. He's well known in this area. He have written books and he have taught manual therapy courses so many places across the world. And I learned a lot from him. So I have to take time to thank him for it. So I'm sure you guys are aware, the world is completely moving away from evidence-based approach. So used to be the evidence-based, then it became like evidence-informed approach. The evidence-informed approach is the one like you will learn the literatures, you will get the information from the literatures and try to use them as it is in the literature. So now we are moving towards, it's called like an eclectic approach. The eclectic approach is the one you read the literatures, gather the information, and use your critical thinking to see if that fits in your patients for them to get better. So eclectic approach is I feel like it's a most well known or well deserved approach where it uses our critical thinking rather than just reading the literatures and doing it. Literatures are great. That's the way we can grow. That's the way we get better. But the problem with the literatures is you cannot recreate the same environment what they did the study on. So say if they did a randomized controlled trial on like say 50 people in a controlled environment, you cannot create the same controlled environment with your patient, and your patient will never be exactly the same as the subjects in that study. So you do not want it to just reproduce the same thing what they said in a literature as a conclusion. Say for example, if someone says ultrasound is great or not great, you don't want to just believe what they said. Get that information. I'm not saying you should not read the literatures. You have to read the literatures, you have to understand the literatures, you have to get the information, but use it to see if that will fit in your patient or not, or in your setting or not. So that's where the eclectic approach comes in. So the main idea for the presentation on the functional shoulder is to make sure we can think critically. So critical thinking, it's not common, unfortunately. Um, we all drilled and trained into just listen to what others say. We do not critically think in most instances. So it's not only in one part of the world, it's all over it's all over the world. It's the same thing here, even in the United States or Canada or New Zealand or Australia. It's all the same thing. Critical thinking is very, very lacking. The reason being, we as clinicians, we stop asking questions. We just go with what the literature said or go with what others said. So critical thinking is a key. If I can make you take one message away from this 1 hour webinar, is just try to always critically think before you do anything. Always understand what you're trying to do and how that's going to make an impact on your patients. So don't just memorize special tests. Don't just do what someone asks you to do and try to implement the same treatment what others have done without really thinking it through what impact it has on your patient. again, when it comes to your patients, you are the only person can make them better or worse. And most situations, again, believe it or not, most situations, we as clinicians, we make people worse than better. And that's where the chronic ailments come in. We When a patient becomes a chronic patient, we as a clinicians are part of the process. We let them go chronic. We let them not to treat them 100% because we are short-minded in a way. We don't understand what's causing the problem. We always look at the culprits where wherever it's the patient is complaining of pain, we try to treat the pain rather than finding out what's causing the pain. So let's go deep into it. All right. So functional shoulder. Okay. So functional anatomy is something we as physical therapists not. I mean, we are the experts in the movement. Okay. So we are movement experts, but the functional anatomy is not something really known yet. There are books out there, but still not fully complete book that to understand the functional anatomy aspect of it. So the anatomical books we read is, even though we are the movement experts, nowhere in the country or the world, the physical therapists are the only people who will understand the movements along with the anatomy and the biomechanics. So try to learn the biomechanics as like a Bible in a way. Make sure we read um, the biomechanics and understand the biomechanics really well. So the functional movements are always diagonal. So I know in anatomy, we always study about the linear patterns. We always study about like a single planar movements, like a flexion, extension, abduction, adduction. We always read about the single planar movements. Those are great, but in reality, we do not use planar movements in any of our functions unless you're purposefully trying to do something in one particular direction. In all our functional movements are diagonal patterns. You always will go in between planes to perform any activity. So in regards to shoulder, you have two main tasks. That's it. You're either reaching over the head or hand behind the back. So these are the two full extreme of two movements of the shoulder. So if we can achieve a patient reaching over the shoulder or a hand behind their back, then the shoulder would not have any dysfunctions at all or should not have any pain. If a person can do these two activities with no pain, no restrictions, no dysfunction, then you have nothing to do with the shoulder problem at all. The patient is perfectly fine. So when it comes to the functional shoulders, so the reason it's called functional shoulder, we really pride in saying the functional shoulder because shoulder joint, it's very, very critical. If we do not understand, I know shoulder joint, I mean, we all studied anatomy. The shoulder joint comprises of like, the glenohumeral joint, AC joint, SC joint, scapulothoracic joint, all those, right? So the one part is missing. I'm sure some of you might know already. So the thoracic spine, it's also part of your shoulder girdle. So if a person does not have a thoracic movement or thoracic extension for that matter, you will not gain 100% of the shoulder function. So the regional interdependence, it's a key. So this is where the critical thinking comes in. If a patient complains of, like, say, anterior shoulder pain, right? Obviously, we are going to treat the shoulder, and most of the times, though, a common therapist, a normal physical therapist will only address the glenohumeral joint and try to do something for the pain, try to eliminate the pain and send the patient home. That's where I said earlier that we are a reason why people become chronic, because we do not understand our body fully. So provocation tests are special tests for the matter. It's great, but that's not the full answer or full diagnosis. I know we all drilled. Again, for the purpose of exams, please always go through the special tests, because that's one of the validated or objective measures where we can show or prove others that you understand the concept. So, don't get me wrong. You have to know your special tests and provocation tests for the purpose of exam, to get through the school. But for in reality, when you come to equals, in my means thing. If you say knee impingement test positive, okay, what does it mean? Yeah, you prove the shoulder has impingement, okay, but why the shoulder is impinged? That's the key, right? Um, Anybody can. I mean, it's not a rocket science to say a shoulder is impinged, or there is a rotator cuff tear, or there is a labral tear. Those all great, and but it's not that harder to find out. But the problem is why the labrum had teared, or why the rotator cuff had injured, or why the patient is having impingement. Why the patient is having impingement, or why the patient is having the shoulder, right? So that is the key. So provocation tests and special tests are great while you're assessing and finding out. Yeah, it helps you to lead the way, but it's not a full answer. So if you stop at the special test, yes, you know what, I found out what's the problem, I'm going to treat the problem, then you're absolutely wrong. So if you say one special test is positive or negative, so you're going to rule in or rule out a diagnosis, which is good. But again, if you stop there, then we do not become a complete physical therapist, or we do not become a good clinician in a way. So always treat the culprit, not the victim. So culprit is the one causing the problem. Victim is the one that's showing the problem. So there's a huge difference. A cervical dysfunction can mimic as or show as a shoulder pain. That patient will come to you with the shoulder pain, but there's really nothing wrong with the shoulder other than it just causing pain because there is a cervical dysfunction or there is a thoracic dysfunction. But if you do not take time to understand and realize and figure out and treat the culprit, the victim, even though if you treat them, the patient is going to come back to you within 6 months or a year, because we did not address the source of the problem. So I think we talked about this in chronic pain. We are a big part of it, and we need to really do a proper biomechanical assessment. And we really need to critically think in assessing a patient. So again, if you're not a critical thinker, critical thinking is not a inborn skill. It's a teachable skill. So we teach when we take our chronic courses to all the therapists in the United States, we teach critical reasoning. We teach critical thinking. So again, as I said, don't think like, oh, I can't critically think, or I can't process this one. It is not an inborn skill. It's a teachable skill. So if you really focus, pay attention to it, if you have a good mentor who can like kind of teach you or navigate through the struggle, what you're going through, you will be able to really understand the problem. You can able to easily identify the culprit and fix them, and the patient will be happier, and the reoccurrence of the particular symptom will be very, very, very minimal, so that patient will never become a chronic patient. I know we love to say chronic back pain, chronic neck pain, chronic shoulder pain, but it's in a way it's a shame that we are saying that, because we are part of the problem. When I say we, probably it's not you, it's someone else, but some other therapist, some other healthcare provider, in a way, they did not do their part when the patient had an acute pain that led to a chronic symptom. So always understand the whole problem, so we can treat the person as a whole. So again, we have to make sure you look at the whole situation completely to understand why you have to treat the shoulder. So that's my soapbox. Let's dive into what we are here for. Let's talk about the shoulder. So I think we talked about this. Think outside the box. Don't memorize special tasks. Treat the person as a whole. So the shoulder joint have three main components: a spinal component, a clavicular component, and a brachial component. So spinal components are the cervical spine, like from L1 to 7. The upper thoracic segments, so especially like 6 upper thoracic vertebrae, that includes the vertebral joints, the ribs, and the manubrium. These all will be part of your shoulder complex. Then the clavicular component, again, the rest of them will be well known. The clavicular component is the AC joint and the SC joint. The brachial component is the scapula and humerus. Again, it's easy to break down into 3 different components. So the reason we break the shoulder into 3 different components, when you do an assessment, again, assessment is the key. Treatment is very, 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 very simple. Once you identify the basic source of the problem, treatment will literally take about 10 minutes. That's all it takes. So when we spend time in assessing, right, assessment takes the longest time. I would say about 80% of our treatment sessions, like when the patient comes in, say if I see a patient for 45 minutes, so about like a 35 to 40 minutes, 30 minutes, that's 30 to 35 minutes, we'll literally go into the assessment section to identifying the problem rather than treating the patient. So if you jump and start treating within like 5 minutes, it's going to be harder to really find out how much you understand the problem and what you're trying to treat. I mean, if you're going to treat that way, that's where we lead to the chronic one. Usually, I mean, what's the common shoulder pain? The anterior shoulder pain. The patient will literally point the finger up here. That's where the pain is, or the rotator cuff injury. The other common one is the posterior shoulder. These are the 3 known complaints, right, from the patient. That's where the patient's complaints of pain. Most likely it'll be the anterior shoulder. That's a very, very, very common, or just the lateral side, or very rarely the posterior side of it. So shoulder dysfunction or shoulder pain could come from, so C2-3 dysfunction. Again, we only have 1 hour of webinar. So really, the functional shoulder, it's a 2-day seminar we do. It is. So I'm going to really touch like basic components. I'm going to give you guys like tips and tricks at the end to teach like a couple of manipulations. I know I made some videos, so it's easy to take something away from the 1 hour webinar, and you can start using them in the on your patients, and you guys see them tomorrow or whenever next time. So that's the whole idea of the program. So the shoulder pain can come from a C2-3 dysfunction. So cervical 2 and 3, it's a unique in its nature because C1 and C2, right, it's called upper cervical spine. And anywhere between from C3 to C7, it's a lower cervical spine. I know there is a mid cervical spine, but we don't use that. But if you go with that category, like a upper, mid, and lower cervical, that's fine. That's fine. But the C2-3, the junction, it's a really transitional zone where the Z joints, the zygapophyseal joints, or facet joints, it completely changes its orientation from one plane to another one in this junction. So there are few transitional zones in our body where it's most of the problem occurs. So C2-3 is one transitional zone, and C7 T1, it's another transitional zone. And thoracolumbar junction, it's like from the thoracic and the lumbar, that's a transitional zone. And this sacroiliac joint, the SI joint. So those are transitional zones. So you would find dysfunctions in these zones very, very often compared to any other part of the spine. So C2-3 dysfunction can lead to a typical anterior shoulder pain. So say, for example, I'll give you a brief overview. If a patient have a C2, C3 on the, say, right side, if they cannot extend into the C2 or C3 spine, that can cause the hypertonicity of like latissimus dorsi. So the liver scapulae, so not latissimus dorsi. So C2-3 dysfunction can cause the hypertonicity of the liver scapulae, which can completely tilt your scapula into downward rotation. So imagine if the medial part of the scapula pulled up, the lateral body will tip down. When the lateral body tip down, it automatically drops the head of the humerus that's sitting on a glenoid cavity down. Then it constantly start creating the cascade of events. So that can lead to anterior shoulder pain. The other one would be like C5, C6, hypermobility. Again, when I say hypermobility, it will be excessively movable. It's not a structural hypermobility. Again, we don't have time to go in detail on everyone. We'll just like learn the verbiages, learn the terms. Maybe in the next time we'll talk more about it. So C5, C6 hypermobility, when there's a little instability at C5, C6 can trigger the anterior shoulder pain. The same thing with the upper thoracic extension dysfunction. So if upper thoracic spine, like from T1 to T6, if it cannot extend, then it can cause the shoulder pain. Again, we need at least about like 20 degrees of upper thoracic extension to have a full shoulder elevation. If so, try to imagine this. You can just flex your thoracic and try to extend your shoulder. You can only go so far, but if you extend it, this will go farther. Okay. The forehead posture. This is actually a common, again, becoming a huge problem lately with the cell phones and electronics and the computers. The forehead posture, it's going to be huge in the future. So you guys probably would see more of this one than what we are seeing right now. But you would see them more and more often, especially the younger kids started using their cell phones, I don't know, at the age of like the 2, 3 now. Their forehead posture is going to be a huge, huge problem, and that will lead to shoulder dysfunction. And obviously, if there is a problem with the AC joint hypermobility, then can cause shoulder problems. So if you guys look at the slide, right? I did not put a glenohumeral joint. Glenohumeral joint, as I said earlier, it's usually it's a victim rather than a culprit. So it usually it's the final joint that gets affected, and it's a final result. The patient will come to the clinic, or the patient will come with the complaints. Usually it's not the source of the problem. These are the source of the problems. Either it's a C2-3 dysfunction, C5-6 hypermobility, thoracic dysfunction, postural dysfunction, or AC or SC joint. Again, these are just a few. I'm not saying the patient would have all of them at the same time, possibly, but the patient would have one or more with these ones. So when you're doing an assessment or when you're doing a treatment, try to remember the sequence. This is the commonest sequence. It'll help you understand the clinical reasoning behind how to assess and also how to treat. So always a mechanical dysfunction. That means, is there a mechanical problem in that particular joint or the particular region, right? So that's where you will assess the glides, you will assess the range of motion. So again, this is not we are not talking about any muscles, we are not talking about any inert structures, which means any ligaments or capsules or just things on those sort. So make sure like the joint is able to move first. If a joint is able to move, then you don't have to worry about manipulations because it's not a problem. So again, this is where the manual therapy comes in where like we do not manipulate every single joint. When I say I'm a manual therapist, it doesn't mean that I'm going to do the manipulations on every single patient who walks to my clinic. It's not true. I do manipulations about like 30% of my patients. So the rest of the 70%, it's just assessing and doing either mobilization or using the muscles or using the ligaments to make it better, not just with the manipulations. Manipulation is just a tiny part of my treatment sessions. But when I say manual therapist, it's the way that you can assess a person much, much better than anybody else. Like in manual therapy, I know there is a huge lenience towards, like, if we say manual therapy, they call it like an orthopedic therapist, right? It's only in orthopedics. But manual therapy, in my opinion, it's all over. And I treat manual therapy I use manual therapy skills for a neuro patient. I use manual therapy skills with the cardio patient. So manual therapy, it just manually you're doing something for the human body. That's pretty much it. It's not an orthopedic, it's not a neuro, or it's not a cardiopulmonary technique. It's you're trying to eliminate the mechanical lesion wherever that is, whatever the patient's conditions are, to allow the patient's body to move better. That's pretty much it. So once you identify, if you cleared up the mechanical dysfunction, then you can go to the innate structures. That means that's where the capsules and ligaments and bursas and everything comes in, right? So once you fix that, then you treat the contractile elements. The contractile elements is the one you should be treating at the last. That means if you're going to say you're going to do some muscle energy techniques or any kind of PNF techniques, if these two are not fixed or treated first and make sure it allows the muscle to do its job, we will not be successful. Say, for example, if a patient have a glide problem in a particular joint, say let's consider shoulder joint, say if the humeral head is stuck anteriorly on the glenoid cavity, for example, and you're trying to have the, like, exercises with the weights or whatever it is, you're not going to get anywhere. We will not be successful with the patient condition because we not gone to the sequence. So always the sequence would be fix the mechanical lesions if there's any mechanical problem. Make sure the patient's joint is gliding properly. If there is no any glide restrictions, then you don't have to worry about it. So mechanically the patient's fine. Then also make sure the ligaments and the capsules are not tight. If the ligaments and capsules are tight, how the muscle is going to overcome the ligament and capsule tightness? It's not. Our body is not designed that way. So make sure the joint is free. Make sure the capsules and the ligaments are long enough for the muscles to function. Then you work on the muscle. So that's the sequence both for assessment, also for the treatment. So glenohumeral joint. So I've taken several slides out. Again, as I said, it's a 2-day course. So taken several slides out. So we'll almost like into past 30 minutes. So we'll talk about a few tips and tricks. Okay. So if a patient comes with the shoulder pain, so you're assessing the glenohumeral joint. You're doing a special test. You're doing a ligament stress test, like all the provocation tests. And you're saying, you know what, the shoulder joint is really good. So the key is, you make the patient lay down. If you can passively do 90 degrees of abduction of the glenohumeral joint. So that means if you can raise the patient's shoulder up to 90 degrees with no pain, and I mean, when I say there's a huge section on how to do a passive movement. I know we all know how to do a passive movement. I think we study in the second year, I believe. It's been a long time. Sorry, guys. So we all know how to do a passive movement, but there's a right way of doing a passive movement, not just lifting the shoulder. When you do a passive movement, you have to make sure you do not move any other joints around the shoulder. You do not move the acromioclavicular joint. You're trying to hold the scapula in place, so you literally do the glenohumeral passive abduction. If a patient if you can do that, like 90 degrees of glenohumeral joint, then the problem is not in the shoulder. So leave the shoulder alone completely. Okay. Even though the patient is complaining of anterior shoulder pain or anything along those sort, if a patient can completely do up to 90 degrees of shoulder abduction, then it's not the shoulder problem. So the easiest technique would be the sequence would be, this is what we found helpful. Again, this is not a set in stone technique. There are times I've changed the steps, but these are the steps I find it most helpful, so I don't miss anything, and also help me to process in my head when I'm going through the technique. So the technique would be, if a patient can reach 90 degrees of shoulder glenohumeral abduction, then you have a friend or a family, anybody who, if you're the only therapist in the clinic, or if you have other person, other PT friend who is next to you, have them do a cervical distraction. When I say cervical distraction, have them hold the patient will be laying down. We'll grab the patient's neck and head, and you gently, again, when I say distraction, you're not pulling the head completely off. You're just slightly applying a manual traction. Hold the traction for about a minute, right? 30 seconds to a minute, okay? If you can, after the distraction, if you can go farther in the glenohumeral joint, but that means like the shoulder joint is able to go farther with cervical distraction. So that means the patient is having some kind of a cervical problem that you need to work on, not the shoulder. So you can leave the shoulder alone, work on your cervical dysfunction, whatever the dysfunction you come up with, the patient will be completely fine. The patient will recover with no time. If the cervical distraction did not make any change in the shoulder abduction, like 90-degree abduction, then you check the AC joint and SC joint. So you do this 90-degree shoulder abduction. If the patient cannot reach 90-degree shoulder abduction, then you work on your shoulder. If a patient can easily do the 90-degree glenohumeral joint, abduction, then you do the cervical traction for a minute and then retest it. If there's increased range, that means the problem is in the neck, work on the neck. If there's no change in the range, then most likely you have to move on to the next segments of AC joint and SC joint and do the assessment. Again, I'm sure we will learn, or you guys are learning already, how to do an AC joint assessment and SC joint assessment. Those are critical and it's easy. It's not complicated, but it's hard to understand. Once you understand it, it's very simple. If you guys identify the shoulder, the glenohumeral dysfunction, so say if you're doing a 90 degrees of shoulder abduction, the patient cannot get to that 90 degrees abduction, then you would assess the shoulder. So there is a condition in the shoulder, it's called shoulder maltracking. Again, these are not like official terms, or it's not in any literatures yet. We are working on publishing a few papers, but the shoulder maltracking is one of the commonest dysfunction we see when there's the shoulder problems. So I will show you how to quickly assess. I'll play a video how to fix. It's a very simple manipulation. It doesn't require like a huge manual therapy skills to apply them. So so I took this video yesterday, and usually I will do it by removing the patient's shirt and exposing that area. So I used my son as a model, and he did not want to take his shirt off yesterday. So please forgive me. So let's go through the assessment, okay? So let me know if you guys cannot hear the video well, okay? Shoulder maltracking usually occurs when there is a cervical pathology leading to shoulder dysfunction. So there are four components needed to confirm the shoulder maltracking, test positive and negative. The first one is a passive elevation of the shoulder. So normally when you pass it, the patient can begin to deflection into sagittal plane with no maltracking. So if a patient have any kind of dysfunction of the shoulder, the maltracking will present when you elevate the arm to about 110 degrees. Then you cannot elevate in the sagittal plane. Then you have to bring the shoulder into abduction slightly. Then the patient will keep going further. So if the patient is maltracking positive, when you do the passive elevation, you raise the patient's arm up to this level. Then you have to abduct the shoulder to keep going to complete the elevation. That's number one. Number two is the feeling the coracoid process. This is a kind of a positional test. The coracoid process on both sides will be comparing to the acromion process, the humeral head. So the humeral head will sit much anterior to the coracoid process on the positive side. The third test would be when you trying to do the glenohumeral glide. When you try to push the humeral head posterior on the glenoid cavity, you will feel it stuck. You will not feel any movement. There's no glide. But when you compare to the opposite side, you will feel the glide present. So the third one will be the absence of posterior glide of the humeral head on the acromion process. The fourth one will be the weak exaltators. So when you have the patient bend both elbows, so try not to let me push your hands in. So when usually you can push on one side compared to the other side. So the affected side, they will have weak exaltators. So these four tests will confirm the maltracking of the shoulder. So just to reiterate that one, right? So again, I don't know how the quality of the audio on this video, right? So the shoulder maltracking, when a patient comes in, when you ask the patient to elevate, right, the patient will be able to go this far. That's all they can do. They cannot go fully. But when you do it passively, Okay, you raise the shoulder in the sagittal plane to flexion. So after a while, like about like 110, 120, again, this is where it's not a fixed thing. Depending on how complex the patient is, it will vary. So, and they will not be able to raise the shoulder, keep raising the sagittal plane. They have to go into some position to continue with that tracking now, right? So different here to the Kroger process when you compare to the opposite side. That's one. Second, when you do the glide of the glenohumeral joint, the glenohumeral head will not glide posteriorly; it's stuck anteriorly. There is a whole the reasons behind it why it's stuck anteriorly that we can talk about it some other time. So the glenoid head will not, I mean, the humeral head will not glide on the glenoid cavity. That's two. The third one would be the patient would have a weak external rotators, and that also goes along with the reduced internal rotation as a movement. Okay, so if you identify all those, then you can confirm the patient have mal tracking, and there's a simple technique we can do to test it up.
Shoulder mal tracking usually shoulder mal tracking. Shoulder mal tracking usually.
Sorry guys, I did not mean to stop the slideshow, but I'm trying to go to the next slide.
Okay, so if a patient have a shoulder mal tracking, there is a simple technique of manipulation actually to fix the shoulder mal tracking. So that's called like a simple shoulder tap technique. So what you will do is once you identify the say right shoulder is mal tracking, you will stabilize the humeral head, okay, to leave the corrective process alone. So just grab the humeral head and you would find the spinal scapula. So you would place your thumb on the spinal scapula and grab the humeral head on the same angle. So what you're going to do is you're going to give a slight tap on the spinal scapula. So what you're trying to do is you're trying to create a quick separation of the loss of anterior glide on the humeral head on the glenoid cavity. So you grab the humeral head and you try to tap the scapula, so it will create the quick separation. So the technique would be, so grab the humeral head, so ask the patient to turn to one side so you don't accidentally hit their face, and then you hold the spinal scapula and give a quick tap. So just one quick tap in a like about 40-degree angle, and then in the line of caption, so the humeral head detaches from the anterior locking of the glenoid cavity.
Okay, so the main idea with the shoulder tap technique or manipulations for the shoulder mal tracking, you will grab the humeral head and keep that humeral head in one place. Do not let that move forward when you do a quick tap of the spinal scapula. So that's the key, right? So you're trying to separate the humeral head. You're trying to create the glide of the humeral head on the glenoid cavity. So you hold one end of the joint and tap the other end of the joint, so it'll create the separation.
Okay.
So, again, this is just like put it in the slide. It's anteriorly fixated, the humeral head. We just talked about the whole technique on the video. All right. So again, so the other joint would be AC joint that you may know or might be new to you. So the AC joint manipulation. Again, so I'll show you both the assessment and the treatment. So the AC joint, it's a planar joint. It's a easy. It's one of the easily degenerative joints. So even at the age of like 10 to 15 years old, or when you're reaching like 20 years old, there is a possibility that AC joint can get into degenerative changes, right? When I say degenerative changes, again, it's all going to be dependent on your body. It will not be exactly the same for everybody. So it could be a mild degenerative changes, or then extensive. Some patients will have much more aggressive degeneration much quickly in their early days. So this is how you assess the AC joint dysfunction.
Acromioclavicular joint assessment. So the acromioclavicular joint is a planar joint, so it's easy to get degenerative changes even at the age of 10 to 15 years old. So people over 15 years old, it's a possibility that the acromioclavicular joint gets stiffened out or locked in, where that could affect the shoulder range of motion. So to assess the acromioclavicular joint, so humeral head, acromion process, and the spinal scapula with one hand, and the other hand grabs the element of the clavicle, and then move the clavicle more anteriorly and posteriorly to check the movement. So if you see any discrepancy between these two sides, then the less mobile side where you perform the acromion clavicular manipulation.
Okay, so again, so once you assess the AC joint, if you identify this one side is not moving as much as the other side, there's an easy manipulation you can do to release it. When you do these two techniques, though, when you do the scapula tap, if there is a restriction, obviously, when you perform the AC joint manipulations, you can easily gain about 10 to 15 degrees of shoulder elevation with no time. So you can easily practice that too.
Acromion clavicular joint assessment.
So this is the treatment.
AC joint manipulation. So if you identify the AC joint restriction present on one side compared to the opposite side, again there is an easy manipulation we can do to release the AC joint between the acromion process and the clavicle. So to do that, so you'll make the patient lay down in the sideline on the affected side, top up. Okay, so you elevate the shoulder. So when you do the manipulation, you do not accidentally stretch any cervical nerves or spinal nerve. So you put your two fingers on the acromion process. So you kind of like grab the shoulder and place two fingers on both sides of the clavicle. So the clavicle comes out this way. So you leave the clavicle in between your index and the middle finger. So you put the index and the middle finger on both sides of the acromion. Leave the clavicle in between. So what you'll do is you elevate it, make sure you're not stretching any cervical nerves, and then you'll do a quick tap. So you'll kind of like tap your fingers, so that releases the acromion from the clavicle with a quick action. So when we do the tap, it's not a straight downward, it's a downward and out. So you will do this like a 45-degree angle. So you grab, make the patient lay down on the affected side, top up, grab the shoulder, place two fingers on both sides of the acromion, leaving the clavicle in the middle, and you elevate the shoulder and give a quick tap. Quick tap. Then that will release the clavicle from the acromion process. So, and you would instantly gain about like 10 to 15 degrees of shoulder range of motion through elevation.
Okay, so again, this is reiterating the patient's position and protect the brachial plexus. That is the home exercise program for the AC joint manipulations. Again, we always have to follow a home exercise program of any manipulation. So once you do a manipulation, you have to teach them the home exercise program. Again, most of the times manual therapy fails because we think if I just do manipulations and the patient will be fine. You always have to follow therapeutic exercises followed by manual therapy. Again, so we probably have to skip the mandibular test because it's a bigger test itself. So I think we will stop with this one. If you guys have any questions, I'm happy to answer. I know we are coming close to a 1 hour mark. I want to be respectful of everyone's time. I'm not sure. I'm sure like you guys have other things to do.